Okay, guys, so today we're going to talk about some MSK bone tumor fundamentals, and I'm going to try to keep this somewhat general so that everyone can follow me, um, and we're going to keep it short for the same purpose, and you guys can give me some feedback and we can modify and tailor these to your needs. So first of all, let's start by saying that for bone tumors, there are going to be some primary locations that we're going to be um, having to look at and some general considerations that we need to have. So as far as locations on this diagram, we're going to see we have a femur that's highlighted in red, and especially the distal femur is going to be an area of increased growth, and that's why we should expect to see more bone tumors develop there. The same thing applies for the proximal tibia. So pretty much around the knees is the side where we can find all sorts of bone tumors. In addition to that, we have the proximal humerus, and that's another side in which, due to growth, we're going to have increased incidence of tumors at this location. So some main considerations to have is obviously going to be the age of the patient, the sex of the patient. So in general, there's about a 1.5 male predominance for bone tumors. Also, like I mentioned, the bone involvement is going to be important, but more specifically, the location within the bone, and that's going to imply whether it's cortical or medullary in terms of the region where it's located. Also, the margin of this lesion, how aggressive the margin looks. So those are pretty much the main considerations, and based on that, we should have a pretty good differential diagnosis, meaning that we're going to be able to narrow the diagnosis most of the time, and we should include around 3 in the differential. And based on that, we expect to include the what's going to end up being the pathologic diagnosis about 90% of the time. So that's pretty good for a simple radiograph. And so let's get started. As far as matrix formation goes, we're going to talk a little bit about the difference of chondroid and osteoid matrix. But the meaning in general is to determine whether we're thinking this more a cartilage base lesion versus a bony lesion with bony matrix like osteosarcoma. So I wanted to go to this image here, and we're going to focus again distal femur. We have the physis here, so there's going to be the metaphysis in this region. There's going to be the epiphysis, and the diaphysis is the long bone or the longer part of the bone. And for epiphyseal lesions, talking about mainly single lesions, we're going to think about 2 things in our differential, and that's going to be the chondroblastoma and the abscess from osteomyelitis or Brody's abscess. And they're going to look very similar. They're going to be located in this region, epiphyseal. They're going to have a relatively circumscribed and not a very aggressive looking border. So that's why we're going to be between these two, and it's going to be a single lesion most of the time. And one way of distinguishing them obviously is going to be based on the history. And the other reason is sometimes we're able to see small canals, and that type of canals will make us lean more towards infection rather than chondroblastoma. But those are 2 big ones. Also, if we're talking about an adult, we can include their giant cell tumor, and that's going to be another bone tumor that's going to be part of the differential for the single lesion. That's the border looks relatively circumscribed, and is going to be in the epiphysis of the bone. So pretty much we mentioned 3 tumors there that you should have in consideration when you see a single bone lesion in the epiphysis. Moving on, we also need to talk about some benign lesions that tend to occur for some reason in what we call the intertrochanteric region, and that's that region between the greater and lesser trochanter. So it's going to be all this area. And in this area, pretty much what we can see is that we can have what unicameral bone cysts, what we sometimes refer to as UBC. We can also have myxofibrous tumors, and we can also have lipomas. And those are all benign lesions that for some reason tend to have a predilection for that region. So that's another part of the differential when we're looking at single lesions, and they are relatively benign appearing borders. The other thing we need to mention is that as part of this, we're assessing the location, whether that's eccentric, the margin, like I mentioned, also the periosteal reaction. So we don't expect any of the ones that we've mentioned to have an aggressive periosteal reaction. And by that we mean any thickening of the cortex. Some people refer to as sandburst appearance for the more aggressive ones that are classic for osteosarcomas, hair on end, a lot of different terminology, but pretty much referring to the same process. And that process is caused because of the growth of the tumor. It tends to create that aggressive appearance. Moving on, you're going to see that we describe sometimes as moth-eaten or permeative lesions of the bone, and we can, for the most part, although they're not necessarily the same, they're very similar, and the differential diagnosis is going to be visually the same. So I recommend you group these two together. And for the differential, is going to be a round cell tumor, Ewing sarcoma, malignant fibrous histiocytoma is another common one, and fibrosarcoma. So those are going to be for a single lesion, one of the first differential diagnoses that we're going to have in mind. Also, we can have osteomyelitis and osteosarcoma present like that. And another consideration will be Langerhans, or obviously metastases are also part of our differential. The only difference between moth-eaten and primitive, I will say that primitive appearance is more diffuse. The lytic or the lucencies of the bone are going to be smaller, and the main differential that we include in this case is metabolic disorders such as hyperparathyroidism, and that will be the main difference between these two patterns. So always in the back of your mind, you'll be surprised how often metabolic disorders can mimic a bone tumor based on their appearance. So it's always something to have in mind as part of your differential. Obviously, for a lot of these lesions, the margins are going to be less well defined, and we're not necessarily going to have an area of sclerosis, meaning bone reacting around that area. And the reason that doesn't happen is because the growth is a little bit faster, and bone in general tends to, like any other part of the body, tends to react to injury or inflammation. The main difference is that it's a little bit slower to react, but in that sense it helps us have an idea of the timing of this insult. And if something's growing fast, or faster than when the tumor can kind of isolate or create that inflammatory response, then we'll see that our borders are not going to be very clearly defined. So all those things, in addition to obviously the age and the sex of the patient, will start guiding us towards our correct differential diagnosis. Going back to the matrix, and that's something that we're going to use to distinguish whether we're thinking more of a cartilage-based lesion or a bony lesion like an osteosarcoma or bony matrix formation. And for that, we think that the x-rays are better, and by that same terminology, the CT. So that's going to be one characteristic that we think the x-rays and the CTs tend to be a little bit better than MRI, because we can assess that matrix formation better. Sometimes for chondroid matrix, we describe it as a ring and arc appearance, and that's one of the important characteristics to have in mind. Although for osteosarcoma, we expect to have what we call osteoid matrix. And another important thing about osteosarcomas are that we should always assess with an MRI what we call skip lesions, and that's lesions that are not necessarily radiographically apparent and that they're not necessarily adjacent to the main tumor or to the one we're seeing. So we might have normal bone separating another lesion that's going to be more distal. So that's why it's always important to assess proximally and distal from the side of the main lesion that we're assessing in the case of osteosarcoma, so we can identify any skip lesions that can potentially change management. So having said that, I think this was a general overview about MSK fundamentals. If you guys have any questions, feel free to post them, and we're going to start making a little bit more of these as we go on, and hopefully we can keep them relatively short so you can watch them pretty quick. Thank you guys.